Right. Good morning, good afternoon. My name is Robin Mensicani, CEO of Deciduous Therapeutics. I'm going to talk for a few minutes today about how we can restore the immune system's ability to remove senescent cells and how that leads to making a best-in-class therapy for lung fibrosis. A couple parts of my talk. First, I'm going to give you a primer on senescent cells and how they're causal to a number of different age-related diseases. Two, I'm going to talk about our lead compound, DCD80, which restores immune function in the lung and how we can position it to be best-in-class therapy. Three, I'm going to follow up on that and show you how DCD80 is useful not just in lung fibrosis, but also in other indications driven by senescence. And lastly, I'll give you a brief overview of the TPP and how we're moving this forward into the clinic. These are indications where senescent cells have been shown to be causal in human diseases, but also indications where removing them in preclinical studies has shown to be impactful in resolving those diseases. So just gives you a roadmap of where a good senescence approach can be applied. Okay. First model is in lung fibrosis. I'm going to explain the model and take you through the data. So in this model, we induce lung fibrosis via a chemical called bleomycin. Bleomycin induces fibrosis and senescence and inflammation in the lung. It happens quite acutely in the model. So by day 0, you're inducing. By day 7 to day 10, you start to reach the peak of disease in the animals. And so what we do is we treat once at the plateau of disease, which is day 10. We give one dose of this drug subcutaneously, and then we look at the impacts on fibrosis about 10 days post the therapy. So just to draw your attention, the black down here is the control animals. That's what healthy looks like. We looked at some cytokines related to inflammation first from the lung. So TNF-alpha, IL-17A are fibrotic cytokines. When they're elevated, you see more fibrosis. When they come down, you see less fibrosis. And so the objective is to reduce these. So we're showing with TNF-alpha, we can go back to homeostatic levels. IL-17A is also attenuated. But most importantly, we see a dramatic reduction in the fibrosis of these animals, looking at not just part of the lung, but the entire lung in totality. So about an 80% reduction of fibrosis in these studies. Visually, that's what it looks like. That's what an uninjured lung slice will look like. That's what healthy and good is. The middle is an injured lung that has fibrosis, so you can see the vast visual difference. But when we treat, you see a significant improvement just visually in these lung slices. Numerically, again, it tracks about an 80% improvement in the animals. We also looked at this from an Ashcroft perspective, which is sent out to a blinded pathologist. We don't tell them which samples are which. We just say, score these. And the higher the Ashcroft score, the more fibrosis. The lower the Ashcroft score, less fibrosis. And so left to right, healthy looks like this. That's what perfect would look like. A diseased lung with fibrosis looks like this. When we treat, we see a dramatic improvement, looking much closer to healthy than injured. Scoring wise, 0 for the healthy control, so that's perfect, as I would say. 5 for the injured, so that's untreated, and then back to a 1 when we use this approach to treat these animals. So again, a dramatic improvement by the blinded pathologist. Okay. Also the collagen 1A. Collagen 1A is a gene that is often overexpressed in lung IPF human patients, and so we wanted to see what would happen in our hands in preclinical studies if we could reduce this. And so it turns out this is what collagen 1A looks like at a healthy level. The higher it is, the worse it is. The worse it is in humans typically tracks with poor survival and poor respiratory function. That's why it's an interesting gene to look at. But with treatment, we see an improvement almost back to baseline. We also put this up against the best current drug in the market called nintedanib. Nintedanib was given this study 10 times versus 1 time of our drug. And we're just showing here that essentially nintedanib does not perform very well in fibrosis, which is well known in humans. But we see with 1 dose of our drug, we beat nintedanib even when given 10 times of the competing drug. So this is one of the reasons we think we could have a best-in-class therapy. If you look across the landscape and the research and literature, we can show head-to-head that we can beat most, if not all, the drugs that are currently approved for IPF. Okay. Second indication, so lung fibrosis is really interesting, but this is not just a single indication molecule. It's a multi-indication impact. And so just showing you a snapshot of some diabetes data. This one just shows that when we give 1 dose of this drug in a diabetes setting, in type 2 diabetes animals, we looked at A1C levels. A1C levels are very stable indicators of glycemic control over time. So they're very long-term indicators. Typically, the first study to get done in the clinic would be, if you're getting diagnosed with diabetes, is to look at your A1C levels and see if they're going up or down or maintaining. And so we should show in this study that even after we first put the animals on 4 months of high-fat diets. We then dosed them once at day 120, and we show that the control obese animals tend to have increasing A1C levels without treatment. The ones we treat, though, go back to normal, healthy level controls from a single treatment over 2 months. So you get a durable effect for a few months from one treatment. Interesting for an IPF lung fibrosis trial because many, at least half of patients who have lung fibrosis also have type 2 diabetes. So you can actually look at both in a clinical setting. Okay, this is the TPP of the compound. So intermittent dosing, everything I showed you today was single dose, small molecule, so very low cost of goods, very good for patient exposure and convenience. Strong specificity of pathological senescent cells. You get really good on-target effects. You don't see any off-target effects, even at 30 times the effective dose. We believe this can be a therapeutic best-in-class for lung fibrosis and potentially other indications. The safety profile looks very clean in preclinical studies to date. The mechanism-based tox also looks quite clean. And most intriguingly, with these approaches, these are given systemically, and so you'll see a multi-indication impact, which I've shown you a snapshot of today, where we get both lung fibrosis improvements, but also diabetic improvements. That could extend into many more indications, as I could explain in the Q&A. So to summarize, failed immune clearance leads to the accumulation of senescent cells. How the immune system, specifically in this case NKT cells, which we activate with this molecule, can be re-stimulated to remove senescent cells. A single dose leads to expanding the NKT cells, removing senescent cells, improving fibrotic and metabolic disease. We don't see any serious adverse events, even up to 30 times the effective dose. The therapeutic window looks quite large. In the upcoming Series A, we will do is focus on testing DCD80 in lung fibrosis patients and associated comorbidities of lung fibrosis patients, which there are many. So sort of a basket study of aging if you zoom out a bit. Okay, thank you so much. Happy to take any questions.
Yeah, thanks, Robin, for such a great presentation. And I think like senescence in general is a pretty mature field in the aging biology, and one of the among the very early which went into clinic. The field has learned a lot from recent trials, so that's very exciting. And I do want to mention is like something which is very compelling for us in Deciduous is like IPF is a very hard indication. It's very difficult to target and everything. So seeing something with a single dose, such a dramatic effect, it's amazing, impressive, and that too beating a standard of care. So that's very exciting there. I think, yeah, in general, what I would be curious to learn how you're thinking of the clinical trials, because in the terms you have two programs which seems to be showing something very interesting result. Would love to, I know we have talked in past, you have some very interesting thoughts around that thing. If you can briefly speak about that, how you're thinking.
Yeah, absolutely. So, IPF is a orphan disease, not very well treated right now, very expensive. It's $200,000 per patient per year, current therapies. The thing about, I think most people don't appreciate about IPF is that there are actually multiple comorbidities commonly associated with that disease. So, for example, half of the patients have type 2 diabetes or are obese. Roughly the same number have cardiovascular disease, renal disease, kidney disease. 80% of them actually have gastric reflux. What's intriguing for us is because those indications are also senescence driven. And the reason we think we'll have an impact on those is not just from the diabetes data I showed, which there's more, but with our approach, it's systemic. So it's a subcutaneous injection. It goes to multiple organs. And so we're showing dramatic effects in the lung. We're showing dramatic effects in the diabetes case. We think there are also going to be effects on the cardiovascular, renal, and liver organs as well. And so you may see an improvement there. So it's just one of the things when you go into IPF, because of our approach, you can look at more than one single outcome. To collect data on other organs, it's a simple blood draw, an EKG, a urine test, et cetera. So these aren't complicated markers to pick up. And so what's nice about that from an investor perspective is, if IPF we think will look quite strong, but it also may look strong in other areas. We can pursue those afterwards as well.
Yeah, completely agree there. So I see we have a question on chat box from Flora. She's asking, is there a difference in the effect of aged NKT cells to be activated by DCD80 versus younger patients?
Yeah, it's a great question. So the question is, does it work in just young or can it work in older? So yes, we've gone up to 18-month-old mice, quite old, done IPF studies there as well. The effect looks quite similar to what I showed with the in this piece of data with the younger mice. Also, what I want to point out on top of that is, it's not just age that drives down NKT cell numbers. Even in younger animals who have diabetes, you see a suppression of the NKT cells, but we can still pick them back up, stimulate them, and expand them even when they're suppressed, even at younger ages. So it's not even an age-related thing. It's actually disease and age together really suppress them. But the good news is with the right molecule, it can still um, activate them and expand them regardless of age or regardless of disease.
Nice. Maybe one next quick question is from Urmila. Nice work. Any thoughts about using DCD80 in liver, heart, or kidney fibrosis?
Yeah, it's one of the things we'll look at in that basket study for the phase 1A and 1B. To do it preclinically, I think was, it's not a focus area right now, but we do want to look at those markers in the clinical studies.